Okay, so after your summary statement, you should just state the problems that you want to discuss. So the problems I want to talk about today include dyspnea, kidney injury, anemia. Oftentimes patients have problem lists that are 15, 20 problems deep, and you really don't have to, nor should you, talk about all those problems on rounds. You want to select the few that are necessary or relevant to discuss. The other thing it will do is it'll prepare your audience for what's to come. So maybe they don't interrupt you later on in the presentation to discuss a problem that they don't think you're going to get to, because they know you're going to get to it because you've stated as much up front. So the problems I want to talk about today include dyspnea, kidney injury, anemia. Now the audience is prepared for to hear about those problems during my presentation. So problem number one, dyspnea, and you want to keep it vague. Shortness of breath, dyspnea. Even if it's slam dunk decompensated heart failure, don't state problem one, decompensated heart failure. Don't do that just yet. In subsequent presentations, once the diagnosis is established, that's okay to do. But up front with a new patient presentation, you really should keep it vague or undifferentiated. So after you state your problem, the first thing you want to do is characterize it. So you want to have a good characterization statement. It's really critical for framing the problem for your audience. So the elements to include in a good characterization statement are time course. Is it acute? Is it chronic? Is it acute on chronic? Is it mild, moderate, severe? Is it symptomatic or asymptomatic? Certain problems are going to have specific features that they, can further characterize them. So anemia, for example, can be characterized as microcytic, normocytic, macrocytic. Kidney injury as acute kidney injury as oliguric, non-oliguric, anuric. So a nice characterization statement to sort of kind of frame the problem for your audience is really helpful. So if you consider the problem dyspnea and you consider these two characterization statements, one is acute sudden onset, the other is subacute progressive dyspnea. Well, in the first instance, I'm thinking pulmonary embolism, MI, pneumothorax, something along those lines. Whereas if the problem is characterized, if the dyspnea is characterized as subacute progressive, now I'm thinking decompensated heart failure or COPD exacerbation or something like that. So it really sets a stage, and your audience is already kind of formulating, a differential or an approach to that problem just based on your first words. So good characterization statement, and then after that, you want to hit them with your leading diagnosis. So dyspnea, subacute progressive. My leading diagnosis is X based on, and now you want to go to the history, you want to go to the exam and the laboratory data and other data like imaging in that order. And you want to go to each of those domains and extract the information that's supportive of your theory or your idea. So again, dyspnea, subacute progressive. My leading diagnosis is decompensated heart failure based on the history of weight gain, diuretic and dietary non-adherence, the elevated JVP, S3 gallop, and inspiratory arousal on examination, the elevated serum BMP, and finally the evidence of pulmonary edema on chest imaging. In less than 20 seconds, you told me what your leading diagnosis is, and you created a nice sound argument for why that's your most likely underlying etiology. Now, you don't want to stop there. You want to include, other considerations. So in this case, it might be pneumonia or pulmonary embolism or COPD exacerbation. So, I also considered pneumonia, but making that less likely. Again, pulling from the history, the exam, and the data in that order. Making pneumonia less likely is the absence of a purulent cough, the absence of fever, the non-focality of the lung exam, and finally the absence of focal consolidation on lung imaging. In less than 15 seconds, you told me that you consider pneumonia, and you told me why it's less likely. In a similar way, you'll go through the rest of the etiologies that you considered, and you'll tell us why they're less likely. I found this to be a really nice way of discussing problems on rounds. It sort of keeps it organized, nice and tidy. And not every problem is going to lend itself to a nice characterization statement, nor will you have a leading diagnosis for every problem, and that's okay. I mean, you can characterize a problem, and it's okay to state, at this time there is no leading diagnosis, but here are the etiologies we're considering, and then you can kind of discuss each one of them. But this is a nice sort of organized, tidy way of discussing problems on rounds. And the other thing is just like anything else that you develop a system for, if you have a systematic approach to discussing problems, it will allow you to discuss a problem on the fly. So maybe during rounds, maybe the labs hadn't come back yet before rounds, and you're sort of surprised to hear about a new kidney injury in a patient that you're presenting on. And your team expects you to talk about that on rounds. Well, there's no need to panic. As long as you sort of state the problem, characterize it, go through that systematic approach that we talked about, leading diagnosis based on the history, the exam, data, you're actually going to more than likely have a very reasonable discussion about that problem, and it'll be organized, and chances are you'll probably come up with a reasonable differential diagnosis and maybe even a leading diagnosis if you just kind of go through it and think about it in that order.